Today we're discussing cultural factors affecting the diagnosis of ASD and ADHD in non-weird population. Ever heard of weird? It stands for Western, educated, industrialized, rich, and democratic. Historically, these are the populations that would often get the most attention in research, but focusing only on weird populations has its drawbacks. Did you know that weird populations represent only about 12% of the world's population, but make up to 80% of study participants in research? ASD, which stands for Autism Spectrum Disorder, and ADHD, which stands for Attention Deficit Hyperactivity Disorder, are neurodevelopmental disorders that affect cognitive and behavioral functioning in individuals. ASD prevalence varies globally, with rates per 10,000 ranging from 34 in Southeast Asia to 203.1 in the Western Pacific, with the Americas at 82.3. Europe at 63.5, and the Eastern Mediterranean at 86.5, while data for Africa is insufficient. ADHD rates also vary by region, with North America at 6.2%, Europe at 4.6%, Africa at 8.5%, and South America at 11.8%. Japanese and Finnish children exhibit the lowest rates, while Jamaican and Thai children have the highest rates. ADHD and autism prevalence rates vary globally. According to recent studies, the pooled prevalence of ADHD worldwide is approximately 5.29%. However, there is significant variability across studies due to methodological differences. Adjustment for these differences showed variation in prevalence rates between North America and Africa or Middle East, but not between North America and Europe. For autism spectrum disorder, rates vary widely between countries, ranging from 0.8 per 1,000 in certain areas of Bangladesh to 93 per 1,000 in Japan. Interestingly, Europe tends to have lower ASD rates compared to Australia and Asia, possibly due to social-cultural and socio-economic factors. However, it is important to note that only about half of the variation in ASD rates can be explained by factors like case definition and identification methods, suggesting that environmental exposures could also be significant contributors. It is important to consider whether symptoms of ASD and ADHD can be manifested in different ways across cultures. A comparative study examining ADHD symptoms between the US and Kenya revealed differing presentations, with Kenyan children displaying more hyperactivity and impulsivity. Additionally, ASD symptoms vary across cultures. In Japan, avoiding direct eye contact is respected, potentially masking ASD traits. Collectivistic cultures provide indirect communication, posing challenges for individuals with ASD. In India, ASD is often misunderstood as karma, leading to delayed help seeking. In Nigeria, repetitive behaviors may be attributed to cultural beliefs. Regarding ADHD symptoms, in South Korea, hyperactivity is linked to academic pressure. In Mexico, impulsivity is perceived as high energy rather than a disorder. In France, stimulant medications for ADHD face skepticism, favoring behavioral interventions. Overrepresentation of weird populations can lead to skewed findings and miss out on understanding the diversity of global populations, including the economic disparity, cultural difference, geographical difference, historical and political background, beliefs, and social norms. This can ultimately result in misdiagnosis or underdiagnosis of mental disorders. Understanding the differences between underdiagnosed and undiagnosed, misdiagnosed and underprevalence in conditions like ASD or ADHD is crucial for addressing healthcare disparities. Underprevalence occurs when people meet diagnostic criteria but aren't officially diagnosed due to cultural barriers or limited healthcare access. Underdiagnosed cases arise from cultural biases, leading to misdiagnosis, while misdiagnosis happens when individuals received incorrect diagnosis due to various reasons like clinical errors, or overlapping symptoms. Clarifying these distinctions helps ensure accurate treatment and tackle healthcare disparities effectively. In understanding prevalence rates for conditions like ASD or ADHD, it is important to consider methodological flaws. Firstly, sampling bias occurs when studies focus on specific populations, potentially not including non-weird populations. Secondly, diagnostic criteria are influenced by cultural variations, impacting prevalence estimates. Lastly, the availability and adaptation of screening tools affect detection rates. These factors underscore the need to carefully interpret prevalence data within its cultural context. Cultural factors contribute significantly to the underdiagnosis of ADHD and ASD in non-weird communities. Socioeconomic barriers, including poverty and limited education, often restrict access to healthcare services essential for diagnosis and treatment. Language and communication barriers further hinder accurate expressions of symptoms, complicating self-reflection and retrospective recall. Additionally, cultural norms shape the interpretation of symptoms, influencing how individuals perceive and articulate their experiences within their cultural context. Using weird-centric diagnostic tools in non-weird populations can have serious consequences, including misdiagnosis or underdiagnosis of mental disorders. This can worsen mental illnesses, reduce access to support and treatment, and perpetuate disparities in mental health outcomes. It is critical to consider the cultural background and context of individuals when diagnosing and treating mental disorders. To improve the biases toward weird population sampling, firstly, it is crucial to conduct comprehensive research worldwide involving various cultural backgrounds and collaborate with global experts and communities to ensure accurate diagnosis and treatment for diverse populations. Secondly, adapting existing diagnostic tools to account for cultural nuances alongside rigorous testing in non-weird contexts. Thirdly, incorporating a behavioral approach alongside standardized assessments provides valuable insights beyond self-reported measures. Fourthly, collaborating with neuropsychology experts to develop culturally sensitive tests validated in non-weird settings ensures reliability. Fifthly, cultural competence training for clinicians alongside prioritizing serious cases and reallocating treatment resources addresses unmet mental health needs effectively. Sixthly, understanding individuals' cultural context informs personalized treatment plans, while diversity training reduces biases and promotes empathy. Lastly, enhancing communication skills through language support and active listening fosters trust and understanding in healthcare interactions. Cultural competence and diversity training are essential for mental health professionals to accurately diagnose and treat individuals from non-weird populations. Understanding the cultural context enables professionals to grasp the nuances of each individual's background and how cultural factors influence their mental health. Additionally, by reducing stereotypes through diversity training, biases are minimized, leading to more effective medical assessments. Furthermore, enhancing communication skills, including addressing language barriers, fosters clear and accurate diagnosis, ultimately improving treatment outcomes for diverse populations.